Thanks very much, Flora. This is my first Find a Cure event, so thank you for inviting me. I'm having a really good time. I think the first three speakers were excellent, so hopefully I can keep the standard high. I'm going to talk today about a big focus piece of policy work that we did a couple of years ago now, actually, working on the highly specialised technology programme. I'd just like to start actually with a declaration of interest. We think that this should actually be the way that patient organisations begin to go, to be very, very transparent about where we get our funding, how we manage it, and how we work. So today I'm talking about a project that's funded by both Alexion and Pfizer. I think these slides are going to be shared so people can find out more about how we fund ourselves and how we manage the use of those funds. So what is a patient charter? It's a method of generating information from our patient membership that we came up with. This is the first patient charter that we've run. We've now produced 3 and we're currently working on another 2. Excuse me. So we've got about 180 patient members and we need patient group members. We need to work to get their opinion together to synthesise it so that we can share it with policymakers. We start off with a workshop where we invite a hand-picked group of patient representatives to come along, spend a whole day or 2 days in the case of our charter and NHS England. We give them a big briefing document before they come, so hopefully people are arriving all on the same page with a good background to the issue and ready to do what's basically quite a hard day's work. We had 16 patient organisations that attended this workshop, including AHOS UK, and we had talks from Josie Godfrey from NICE, John Sussex, who's a health economist, Robin Lackman, who's a consultant in metabolic disease medicine, and Will Evans, who's a patient representative. I'd just like to say at this point, you can see Josie participated on the day, Heidi actually came as well. Both of them spent the whole day there, giving up a full day of their time to work with us to make sure that, if possible, we had answers to the questions as we developed the policy work. And we found that NICE had been collaborative on our policy work all the way through the work we've done. So I've got no complaints there, and thank you very much for that continuing good relationship. So the model is to make sure that all of our groups can really contribute to the work. We broke out into 4 sessions that were facilitated by people there that we'd asked to do some more hard work for us. And at the end of the day, we came up with some key topics that we eventually used to organise our patient charter. So we then go away and spend quite a long time writing up all of the notes from the day. The charter actually came out with 29 recommendations and it's about 40 pages long. So I won't go through every single recommendation today, you'll be relieved to hear. But really it's supposed to be a collaborative document and we really took a lot of care to make sure that the people that were there agreed with what we came up with in the end. So we circulated it around everyone that came and they had the opportunity to feed into what we said. After that, we then finalised the document and sent it out to our membership, the broader membership, most of which hadn't had the opportunity to come to that workshop, and they had the opportunity to put their name to the document too. Eventually, we gathered 78 patient organisations to support the recommendations that we came up with, and those in the pink box are the group that participated in developing the charter, and actually AHOS UK were going through the eculizumab hearing at the time and probably felt that signing up on a policy document recommending that the process change might not be a brilliant political move, so they didn't sign it. But Leonard and his colleagues did participate in developing the recommendations, and we actually learned an awful lot from AHOS UK, who at the time were the only organisation that had actually been through the programme. So I'm going to talk a bit about some of the recommendations. I actually want to really focus on one, But I'll get to that. First of all, we had a premise in our charter that the existence of a program to look at diseases, treatments for very small patient populations is necessary. That we shouldn't have just a one-size-fits-all approach in England or the UK. And that's quite an important thing to just get out there at the front first, because some might say that, you know, these treatments aren't cost effective when you compare them to treatments for bigger populations, and that it's just unfair to have this program. But as the previous presenters have detailed very well, it's really hard to get a grip of how these medicines work. The evidence levels are much lower. It's hard to see, compared to treatments in bigger populations, the value of these medicines. So we really felt that we should put that out there at the front. And also, there's been really quite a lot of academic research on this topic, and has consistently come out with the idea that there should be an exceptional program for this type of population. So I'm going to go over a few of our recommendations now. Essentially, although this blue statement doesn't quite capture it, the HSD program was found to be a positive one, and we were pretty pleased with the core process of it. But there were quite a few things around the process that our members felt could be addressed. Some of them have been addressed in the year and a half since we published this document. But the key findings are these. But first of all, it was a really interesting outcome that surprised me, certainly, that the group that attended the workshop were quite concerned about a few small comments that were made through the day around the risk-benefit of the treatment. So the way market access works is, first of all, the European Medicines Agency looks at these medicines and decides, are they safe? Do the benefits outweigh the risks? And then we make our decision on funding it, which is, are they cost effective? Does the actual value of the medicine make it worth paying the price that's set for the treatment? And there are a few things that just came up during the workshop that made us a little bit worried that the committee might start thinking about the risks of the medicines again. And we felt that actually the patient community have put in quite a lot of hard effort to convince the European Medicines Agency that these are safe treatments, and they support the risk benefit. So we found that really interesting. We haven't actually seen any sign of that cropping up since the document. But, I've actually seen a little bit of it at NHS England in the way they speak about the work they do as well. So it's something I think our community should just keep an eye on. You don't want to make the same decision twice. So this risk of downplaying the patient voice, it's the key points here were we felt that in the case of AHOS UK, if there hadn't been the previous process that Len described, then the patient voice might not have been as strong as it turned out to be, and we know it was crucial in the decision-making process. So the previous decision-making body, Agnes, had found funds to pay a consultancy to support AHOS UK in developing their crucial qualitative research. And we felt that's, well, basically a brilliant idea, and something that NICE might want to think about doing to ensure that there's a more stable level of quality of patient voice, and that other patient organisations that might not have the funds to be able to support that research should be funded to be able to do the same thing. And we thought that actually, if there hadn't even been an organisation called AHOS UK and there was no organised patient population at all, then maybe the outcome might have been different. And that would have been a tremendous pity and kind of just an episode of bad timing and kind of roll of the dice. And we think that there could be ways in which NICE could level this out a bit and find a way to support every patient organisation so that that crucial voice is more balanced. Blabbering on a bit here because I want to focus on the bottom one, sorry. I'll try and be quicker. So the definition of clinically distinct was felt by the group to be outdated, actually. This is a part of the criteria that allow your treatment to be selected for the highly specialised technology programme. And the phraseology is around the condition that you're treating being clinically distinct. And this essentially rules out subsets. So we mentioned Glyco earlier actually, that's for a mutation of cystic fibrosis, not cystic fibrosis itself. So you'd have to look at the patient population of cystic fibrosis to see whether it's eligible for HST. And there are many more people with cystic fibrosis than there are eligible for the Glyco treatment. Now actually, with the nice evaluation of the treatment for Duchenne muscular dystrophy, this has clearly not been applied, and we were quite pleased to see that happen. But I think, well, we think it would be good if that was formally acknowledged as a change of approach. Because we're basically just talking about small patient populations. And there are lots of different ways of having small patient populations. There might be a treatment for breast cancer, which is a common condition, that is only applying to about 100 patients in the UK. And if the best route for that to be evaluated is an HST program, then fair's fair, then another rare disease patient population should be able to use that route if it's the most appropriate, and the people that decide which topic is selected into which process think that the HST program should be used, then brilliant, let's use it. At the moment that might be difficult. And finally, before I start talking about the transparency in the topic selection process, we were worried about potential disruption to the wider NHS, which is essentially when an enormously expensive treatment is mandated for commissioning because it's cost effective and NICE have done their process, which we found to be excellent. Then how do NHS England handle that massive change in the way they allocate their budgets, and what happens to the budgets that they've already laid out? So we were concerned about that. Actually, we haven't really seen any clear evidence of a massive disruption when eculizumab started being commissioned following the NICE recommendations. But we feel like there could be better collaboration between NICE and NHS England on how those resources are allocated. Just a better overlap. And actually, it seems like maybe this year might be the one where NHS England really finds itself quite cash-strapped. And actually, if we're looking at pieces of medicine evaluation policy that really have a massive disruption effect on the wider NHS, and the Cancer Drugs Fund is probably much, much more disruptive than the HST programme ever could be. But anyway, now I want to just say a bit about what our members felt about the transparency in the topic selection process. So this was a clear point that the way in which treatments are selected to go into the HST programme needs to be more transparent. And we were doing this work back in 2014. I need to be clear about that, as you'll see later on. Because we thought the HST programs are a really good way to show the benefit of a treatment for a rare disease. But if there are only 3 a year, then how do you pick those 3? That could end up being really crucial if the other way that you get your decision made isn't as good as the HST program. So we were really keen to see how that worked. And we found that there wasn't a great deal of information. We learned something from the Horizon Scanning Centre, who provide reports to NICE to make the decision. And to just illustrate how this topic selection point is so crucial, and to potentially start or have a little bit of a go at answering the question about what happens if you don't get into the HST programme. This is a map that we made for our second patient charter, which was on access to medicines via NHS England. So on the left you've got the NICE programme, and you've got the multiple technology appraisals, the single technology appraisals, and the highly specialised technology programme. And then a route to patient access at the bottom. But if you don't go through NICE, then you're likely to have to go through NHS England, where there are a lot of different routes. Those pink boxes are the clinical reference group route, where eventually you'll end up at the clinical priorities advisory group and might have a decision. The Cancer Drugs Fund, which is a much quicker way. Individual funding requests, which aren't a very good way to access your medicine. This is a new one, the clinically critically urgent route, which allows you to get access to a treatment before a formal commissioning decision is made, or commissioning through evaluation. It's quite complicated, And personally, I'd rather go through NICE. If I had a treatment that kind of met kind of characteristics that eculizumab came about. So how did NICE show their topic selection process? They have actually come to decide to make this process more transparent, and this is from the NICE website, where essentially they're announcing a decision to be more transparent. Now the kind of rates of decisions of, so topic selection is where you look at a medicine that's just arrived and you say, shall NICE look at it or not? And before 2015, there was a lot of confidentiality in the report. So the spreadsheet says the confidential product was considered for the confidential indication, and the result was confidential. So that's that line down there. And then you can either develop the topic or not proceed. Essentially, it's more detailed than this, and the spreadsheets are all online. I just want to show here that before 2015, the not proceed rate was higher than it is in 2015. And I appreciate that we've only had 1 year, and it's a new process and all the rest. But I think it's interesting to note that there have been really very few do not proceed results from topic selection in this year. Now we have a more transparent approach. So I was interested to see, why are more treatments being prioritised. So this is the spreadsheet. I'm not going to go through the spreadsheet, I promise you. I just want to show you this column though, which is the decision and the rationale. And this is actually the spreadsheet for a single technology appraisal program and multiple technology appraisal programs. But the rationale, unfortunately, for every single positive process is exactly the same, that anticipate the topic will be of importance to patients, carers, professionals, commissioners, and the health of the public to ensure clinical benefit is realised, inequalities in use addressed, and help make the best use of NHS resources, which is a really good reason to do health technology appraisal. So these are the numbers here. And we are really pleased that NICE is moving towards a more transparent process, but we feel like it would be better if we had an individual rationale for each decision as to what happens, because if you're getting your do not proceed result, then it would be good to know why. But the strange thing is happening that there aren't really any do not proceed results anymore. So it feels like if almost every single answer is yes, then the actual topic selection decision is happening somewhere else. Is it happening before, so actually all of the good ones are going through and we're getting loads of yeses? Or are they all being rubber stamped to be filtered out in a later process? Or are we really lucky and there's loads and loads of treatments that are perfect for NICE? And that's brilliant. I'm not sure. I haven't had the time to go into this in further detail, but we are quite concerned at Genetic Alliance UK about this situation, purely because if we go back to this map, it is a mess out there at NHS England at the moment. They are improving their approach, but personally, as I say, I'd like to be evaluated by NICE if I had a brilliant treatment at the moment. So I want to, where are we going to? These are the links to download our charter. I think the slides are going to be sent out, aren't they, Florence, so you don't all need to scramble to write this down. The top one's our charter on NICE, and one of the big findings of that charter was, wow, it's a mess at NHS England, we should probably do that one as well. So the second charter is about the NHS England process, and that was done last year. The processes have changed a bit, but I'm still getting feedback that these documents are quite helpful just to understand how things work. So you're very welcome to use them to do that, and with credit to us, then you're very welcome to share them and use them in your own presentations. Lots of acknowledgements for all the really constructive help we had from everyone we worked with on this, and a reminder, including NICE as well, we have really enjoyed working with NICE on this. And thank you very much.